This is a podcast where experts in movement and life tackle current concepts in health and wellness and use science and evidence as the foundation of how we discuss each topic. This is not medical advice, but a sedentary lifestyle is much more harmful, so we should move. The Motif Experience, where movement and life come together. I'm your host, Dr. Tyler Cuddy-Ford.
I have to, before you, I'm going to send you a 2-hour YouTube video.
Yeah.
Will blow your mind.
Yeah.
Yeah, it was on the way back. I would listen to YouTube videos all my 22 hours.
Right.
It's by, I think, Heberman, a neuroscientist from Stanford.
Yeah.
And first, you'll love the first half hour is like a waste of time, but
Sure.
you will appreciate it.
Yeah, right.
It's his story of his life.
Yeah.
And he's like so about you, right? Like, you always like to give guys second chances.
Okay, yeah.
He was a delinquent, basically.
Oh.
From just because of all these circumstances.
Right.
But now he's like a premier neuroscientist, and
That's cool.
it's pretty cool, right?
Yeah,
and so, but his podcast is just, he's all about looking at the brain from a chemical channels. Like, he doesn't talk about it this way, but he talks about the nervous system.
Right.
But he sees it as like norepinephrine, acetylcholine, dopamine, and how that predicts all these different things.
Okay.
And it's completely cool.
That's really interesting. I didn't. So,
but
I've got something for you.
Okay,
I'll do that. So I'll write that down or send it. So that way I'll know.
Yeah.
Affective neuroscience.
Okay.
It's Andy Bassaros turned me onto it.
Oh, okay.
I started reading one of the books.
Okay.
I don't remember the author's name.
Right.
But if you just typed in affective neuroscience, he'd pump up. It's a Hungarian name, I think.
Okay. Yeah.
And he's done midbrain research for 30 years.
Okay.
And it's the thalamus and centers of that. And he's I wouldn't say he's a cognitive neuroscience, but affect was emotions and things like that that he was interested in.
Yeah.
But you read his work and he's not into pain. But everything about movement and pain it's the switchboard.
Yeah.
Right? And so, the trauma, all those kinds of things that he talks about, related to kind of the domain that he is researching.
They could be the same people. No, I mean, it's true.
No, I don't think it's the same piece. But
well, this guy talks about the autonomic nervous system and trying to control the autonomic nervous system.
Yeah, it's a weird name. Actually, JD can pop it up. Affective neuroscience, and then, but anyway, I don't think anybody's really, because we've struggled a little with our own identity with pain.
Yeah, well, everybody.
GFU does, because we don't have a model.
I thought you guys did the pain neuroscience education program.
Well, yeah, we do, but it's someone else's model.
Oh, well, right. We don't have our. Oh, you mean our own unique model of pain? Yeah.
So we're borrowing from Mosley. We're borrowing from O'Sullivan. We're borrowing from.
It's kind of a mishmash, right?
It is a mishmash, and we borrow from Saluka. Some of that in the pain course.
Right.
So we don't necessarily have our own model.
I'd say I'd say it most closely aligns with O'Sullivan, because O'Sullivan,
it's true,
because he umbrellas all that stuff.
And then I think we're more about movement than most of the other,
which would be consistent with O'Sullivan.
Which would be consistent with O'Sullivan for sure.
Yeah.
And then, but what was interesting about this book was they talk a lot about how. The affect is changed, but when Andy talks about the thalamus, that's the gateway for nociception and movement.
So that's was it the spinothalamic tract comes up?
Yeah,
thalamus, right?
Yeah. Now we're talking things. Exactly. So anyway, it's worth thinking about because that. Oh, I hear this right here. So it's Jaak Dan Sepp.
Yeah, that's not
so. No, I know. I knew it wasn't. So
anyway, so all right. Well, all right. Well, no, that's cool. So I want to read it. It's like because see what happened in this podcast. It was because he did things like how does a seal succeed? Because
a seal lion or a seal
trainer.
Seal trainer.
Because not a seal military guys.
Yeah. Right. Yeah.
Because basically they're all tough when they go in.
Right.
There's every reason for every single guy to win.
Right.
And none of them get kicked out. They
get kicked out.
Mm-mm.
Yeah.
No, they quit.
Oh, I see what you mean. Yes, they quit. They quit.
But they quit. None of them get kicked out.
Oh no, that's true. Right.
They all tap out.
Yeah. Right.
When they give up.
Right.
And they're all badass when they go in.
Well, there's a couple of that's not. Yeah, that's 100%.
Yeah.
They are out of control.
Yeah.
Right. And so you want them on your side.
Yeah. Yeah.
So I do know a little bit about it. So some of the SEAL trainings in the pool. Well, a lot of the SEAL trainings in the water, right? Because they're SEALs, Navy. And so there's tasks that they have to do on the bottom of the pool. Mm-hmm. That requires them to hold their breath for a very long time.
Yeah.
And so there are some people do get kicked out because they pass out underwater and have to be resuscitated.
Yeah. So they're dying.
Right? So they have to leave.
Yeah.
But what's interesting about they get invited back.
Oh.
Because they have the no quit gene.
What quit gene?
The no quit gene.
Oh yeah.
Because they'll go until they pass out underwater.
Right.
Knowing they've got a high chance of, they're breathing in water, all that stuff, right?
So they still will stay with it.
So, yeah.
So they want them.
They want them
for something
else. So that is, they want them to reapply and come back because...
Yeah. Who has that?
Who has that?
Yeah. So what this guy tests is he has figured out, he thinks he's figured out why some succeed and some don't.
Oh, yeah. That's great.
Right, because that's in spite. So he's saying it's not resilience and all these things because
right.
they already have it, right? And so he's published a lot on this.
Do you remember his name?
I have his. I'll send it.
That's
I'll send it. It's Heberman. Try to enter Heberman, Stanford Neuroscience. I'd see if something comes up like that.
Yeah.
I think B's Heber.
Oh, Heber.
Heber maybe, but I could be completely wrong. So it's just I only listened to him for 2 hours.
And he said his name one time.
I know, right, exactly.
Huberman?
Yeah, Huberman, that's it. Okay. So, but anyway, I don't know. Are we going to start? Are we already on?
Well, she's already here. This is great.
So one of the things, I did have something from last time I thought about. I was listening to a podcast last night, and it was just talk about stuff, and I think it's interesting right now because I had on the 50/50 podcast, that I'm doing. Mm-hmm. I had Joe Godges on the other.
Right, yeah, with Dan.
Yeah, it was awesome, and he's amazing and has done a lot for the profession, right?
Yep.
But basically, he's pushed, clinical practice guidelines.
Yeah.
And so we're talking about the
and manual therapy.
Yeah. Right.
Yeah.
But we were talking about the low back pain one.
Yep.
Right. And I was just trying to, create a discussion about.
Yep.
The psychological factors, right, and how that blended with performance, right. And he was so interesting because he was just like, he wouldn't take the bait of they hadn't been about psychological informed at the time because they basically have in the guideline counseling and they have all of these psychological assessments.
They do mention it.
They mention it, and then he has counseling as an intervention section, right?
Yep.
But
they list it as a barrier.
Right, and
but
something
but what to do with that? They don't.
Right.
They don't.
But at the time, there wasn't enough data.
Is that 10 years by now? Is it close to?
It'll be 10 years, and it's 8 years old.
Okay, 8 years old. Yeah,
but
it's close.
But he did a reveal, like he said. Essentially, they've just done they're doing a new guideline on psychological approaches.
Okay,
so it's pretty cool, right?
Okay.
So that's appropriate. But he's like he kind of. But he didn't, and I think it resonated with me. It's like we were on it in 2012. It was current and to the best that we could do at that moment.
Right.
And then as I was thinking about what he was saying and looking at it, I think he's right. It's like the foundation of psychologically informed PT was there at the time, but not fully fleshed out, and so it would have been unfair to put it in the guideline more.
Without question.
Right.
Yeah.
At the same time, I think, in what and then this quote from this podcast I listened to last night, it's like you get into this thing about, move quickly and break things to cause revolution, right? Do you know what I mean? It's like move fast and break stuff, right? And then that makes you look cool and makes your podcasts look great, right? And it's like it was nice because I think I pushed him on the guideline and said, how does this lead into psychologically informed PT? And I mean, I think he saw that as like I was trying to move fast and break things to make my podcast better. Right? It's like, and I just have this sense that, it's like, it's so nice sometimes to have like this connection to how things build. Yeah. Because change isn't moving fast and breaking things. And I think what resonated with me when I heard that, and it was something that you made us do when we first came on here to you asked me to give us all these books to read, and one was Good to Great. Yeah. And that book, had good leaders and not so good leaders, right? And one of the traits of the great leaders that lead these programs was not the guy who comes flying in and is all flashy and all that. They almost always fail, ruin the companies. But it was like the trait, they classified it as a hedgehog, which is a completely boring, animal that hides in the dirt and digs stuff, but is relentless. Right. And very detailed and but also innovative and things. He does his own thing, right? So I just thought that was, it's just interesting to think about, like, as you think about what is leadership and, how do you connect to the past and things like that. And I think I'm a little sensitive to it just because, we did these things and now I'm like looking at this stuff and it's like, it's exactly what I did. And I was like, who would do that? And I'm like, well, I did that. And it was for good reason. So I would just say to people, think one day you're going to be that person that did the thing that you're like, who does that? And it was like, well, that was me, right? Because things change, right? And your perspective changes, and that's good, right? And I think we need to change and do that. So it's just interesting that quote of like, move quick and break things. I think it encapsulated really quickly some angst I have when I hear certain things about, why would we do this and all that. And I would just say it's probably because, though, some of the things we're seeing right now are really cool and they're very big shifts. And so I think the good side of that is we need to get on board with them. Right. And then really try to understand them and embrace them and get rid of these things that we weren't doing. I think that's part of it, right?
I appreciated your comments, in our last podcast about, because you and I did practice patterns that are inconsistent with current guidelines now. That's clear. As we, kept informed. Yeah. So then this is kind of what this podcast is about. Right. Keeping clinicians informed. Right. It's a major theme, I think, that we want to do throughout each person we talk with. Yeah. But I think that's the result is as we became informed, because we're in academics and we like to read, and it's interesting to us to find the article that moves fast
and breaks things. Stuff, I know you and I both like to break things.
We do. So. And so I at some level, that's the starting point of getting people's attention for a new concept. Right. So, pain neuroscience education did move fast, and it broke things.
Right, 100%.
Right, when it first started.
Right, which is interesting now because I would say that's a great example of something that's going to be majorly reformed because it doesn't work without movement. Right. But that's already just in a few years because we're moving much quicker right now.
It is.
Yeah.
Right.
So that's a good example. All those people with pain neuroscience with their diagrams and stuff need to rethink what they're doing.
Absolutely. Right? Yeah. Stop talking.
Right. And and the other, one thing I thought that was interesting on this neuroscience podcast that I heard recently, and I thought, it was really important, was it kind of resonated with this, which is why I do think we need to get into more neuroscience and not just psychology, right? Yeah. And so
I'm going to back you up on that. Without exception, that's me too. Because when I started reading, this Pansec. Is it P or Dan? Sorry, it's Danksepp. That's it. Dank.
It's a peak.
Oh, is it?
Yeah. It's a peak.
Panksep.
You're going to have to look for it.
It's definitely a peak.
Our producer will do that. JD's going to be great. So, and then she'll bleep out all this stuff that I'm butchering this poor guy's name. But that's what intrigued me.
Yeah.
Learning more about neuroscience.
Yes.
And the pathways and the connections that these all have. So Andy's got the Lundberg /
the
Sherrington model. Right.
Yeah, the circuitry,
when Sherrington, first developed, that's what I always like about, one of the things I like about medicine. You remember, we talked about when we took the skeletal biology course in Iowa.
Yeah.
Did you take the course?
I don't know what you mean. I'm not sure I did.
Okay, so it was.
In muscle.
The
with
muscle.
Dr. Darling.
Yeah, with Dr.
Yeah,
Darling.
I didn't do that course.
You didn't do
I know.
I mean, he started early on in muscle models.
Oh, okay.
And so the more that we know, the more that we refine the model.
Right.
And that's always been an important concept in medicine. The more that we understand about the behavior of a system or a cell or whatever it might be, we then can apply a little more information to get a better model.
Well, so just, will you finish your point?
Oh no, that's it.
Well, so the
Lundberg model is a little more complicated because we understand that the brain the nervous system is more complicated.
Right.
And we have now connections in the spinal cord themselves. They don't have to go to the brain.
Right.
So I like this guy. So now this affect or movement, all these other kinds of things can influence pain. So I think at some point, like the pain neuroscience education, it didn't get at, I guess, the why that works.
Yeah, there was no explanation.
Neurophysiological, no mechanism for why that works.
Yeah.
And so I guess maybe your guy, and then some of the stuff that I'm currently reading as well might elucidate some of those things.
Yeah. So two things I think about since we're on it. I think two articles that stand out for me is one article which I can give the reference to later, but. One of the things they did was a theory article, and I've been thinking about this too. It's like this evidence-based versus theory versus qualitative data. Yeah. And I think they're all three need to interact more. Okay. We've kind of gone a little bit more too much evidence-based, and this would be a good example. Like, the theory of neuroscience pain education would be because you provide somebody with this knowledge that then their fear could be mitigated. Right. Okay, well, so you can test that theory. Yeah. And there was a really nice article by O'Sullivan's group. Like, he's a co-author. I don't know who he did it with. Right. But it was where they looked at, pupillary dilation, sweat, and
some other
like heart rate, as autonomic responses. And then they looked at it in terms of whether showing flashcards.
The images.
And then they calibrated bending and fearful activities, and they were all afraid of bending.
Yeah, I've read. That's a great one.
Right, and then basically they calibrated the responses to spiders and things that they actually
you're supposed to be afraid of,
and that they can get a response from, they record, and then also on the other end they kind of. To pleasure, like ice cream, wonderful things, and so
it's a great paper.
It's a fantastic paper, and they just said, "Hey, can you elicit fearful responses from education?" And the answer is no. You can't do it, and so
you can show a picture of someone bending, just to help our listeners. So you can show a picture of someone bending, and there's no autonomic fear response.
There's no fear response, and so what it means is that essentially it's intellectual, right? And then so the guy from Stanford, what's his name?
Huberman.
So in this podcast by Huberman, they're talking about all these neuroscience things and education, and the discussion centers around you think that cognitively you have to think about something before you do it. You have a challenge in front of you, and then you can kind of regulate your internal thoughts and fears and things like that before you act. Okay. But that's not really what they're saying. Is it's inverted. Like, people, it doesn't make sense, right? He says what they say on the show, because of the nervous system reactions, is agitations are required for a change, and that essentially you need it's action. Mood follows action. Mood doesn't precede action, right? And so And so it was really great concept, right? And so I was like, that follows exactly with what, graded exposure is about and these different things, right? And that if you want to change, like if you have a change mindset, right?
That's great.
It's fantastic, right?
Our first primary care data, right? So we measured 5 things, 4, maybe 5, I think. Self-efficacy, pain interference, self-efficacy.
Right, we said 5 things. So self-efficacy, pain interference, physical function, fatigue, and depression. Yeah.
So the very first, this was 3 years ago, 4
and
years ago.
The promise scores, right?
Promise scores, and we've talked about that. So PROMIS. So if people are listening, they need to look that up because it's still
fantastic, right?
Yeah. When we move people, people's mood get better.
Their self-efficacy goes
up.
up.
Their self-efficacy goes up.
Yeah,
and we at that point we didn't address it because we didn't know.
Well, so
now we are. We're trying to get a handle on what motivational interviewing might be. What some of these psychologically informed models, like what you're doing and Dan, and so that's what stood out to me. 4 years ago, it was like we didn't talk about this, but yet they got better.
They got better, right? So the movement. So your premise at the time was like, hey, do you really, and I've heard this a lot, do you really need to do psychology because movement itself can be effective?
This is where you and I battled for how long? A year.
I know. We were both extreme, right?
So I think so. Right.
It's everything. It's nothing.
It was really great. It was like, no, you're wrong, Jeff. It's not about.
No, you're wrong.
And then he says, no, you can't move without. So. We're both right.
Exactly. I think that's true.
So I think we did kind of have as we're learning, I think that's move fast and break things, right? So we're moving fast and breaking things, and then so are you.
We're both going different extremes, right?
We're breaking 2 different things,
right?
So,
no, I respect that. So so it's, I mean, to me this is super fascinating because if you, it's kind of consistent with everything kind of overlaps, and that's, I think it's unfair really for everybody right now. It's like it's a big, zone of confusion. Because it's like even the different psychological theories, which is why I decided to do 50-50. It's like they have no, ACT is correct. Right. No, social cognitive theory is the best. No, social determinism. No, there's all of this language and confusion and high level talking, right? And it's like, and take for like example, task self-efficacy and regulatory self-efficacy. They're both important concepts, right?
Yeah.
And what it is people confuse them, right? And they're really important because see, task self-efficacy is what you get confidence in doing a task.
Right.
And so like you can say to me, hey, I'm safe on the treadmill. I can modulate my physiologic thinking. I can understand that a high heart rate is good.
Yeah,
I modulate the pain and stuff, different things I'm feeling. I feel secure in that. But that doesn't translate to me going out and walking.
Right.
So that's a different confidence. See, I can do it here with you in this, safe environment for whatever reason.
Right.
But if I want to walk or if I want to go up a hill or something like that, it's a completely different context, and it won't translate until I do it on my own without your help.
Right.
Right. And so that's regulatory. And so what's more impactful, and this is the thing that I just learned, the last year or so, is that task self-efficacy is what we like as PTs, and what we always do, and that's why we always get confused.
And we're coaching them along, and we're trying to get them to do things. And,
so we get confused when someone says, "Hey, you're not giving them self-efficacy," or they're not. This is not really helping them psychologically because look,
right.
It's all happening, and yet what's funny is like they don't go to that doesn't always translate into, hey, I'm going to go to the grocery store, push my cart around, or I'm going to go climb this hill with my wife or kids or whatever because I did it here, but there it's like this morning I went for a walk and the one hill's all ice.
Right.
So you have to go over on the side of the curb and everything. And so all those factors become contextual that are unrelated to, a treadmill walking or whatever you're doing in the lab. And so the idea, and also just barriers for doing stuff like, oh, I'm tired, or oh, I wanted my coffee and snuggle, or whatever it is, right? And so see your own motivations and things like that to be overcome and be able to actually do things for yourself and trust for you. Those are much bigger than just coming in and with you walking next to me doing the treadmill. Right. And so I think for me it's been nice. The whole psychological frame has been really nice, right? And that's the benefit of like all these terms and all this jargon and everything. But at the same time, it's super confusing to know, like, because all these different competing, psychological frames claim victory,
right,
and claim superiority. Like
right.
ACT therapists are all about acceptance,
right,
and then
right.
Other people are about confidence and value-based goals, and,
right.
all these different things. And so it's really right now this what I think is this competition, really.
Yeah.
And so I think we should let it play out, but at the same time understand that it's going to be confusing for a while.
Yeah.
And so I think that's a good place for us to go as PTs, because we can help sort it out, like what's good for us, what's good for our patients that need performance enhancement.
I'm going to play a little bit of the devil's advocate.
Okay.
Because I'll use dieting as an example.
Yeah.
Okay. So, and we can name, I don't know, a dozen different diet programs. Whether it be the Caribbean diet, the paleo diet, I mean, it goes on and on, right?
Right,
so
right.
you can figure out what other those are. And each of those plans, Jenny Craig, Weight Watchers, each of those plans have I call them a poster boy, poster girl.
Oh, right.
Right, because
Some
some person that has been amazingly influenced and successful.
Yeah, like the Subway guy.
Subway guy.
And what's his name? Jared.
Right. So, and so each and every one of these has success.
Right.
Measured by a number of people.
Yeah.
That are influenced and they win.
Right.
So
that's vicarious learning.
Yeah. So
they're using that.
But more people fail than get better.
Oh yeah.
But every single diet works.
They can work, right?
Yeah.
If they do the diet.
right. So I think that's the same as what we're just talking about. All of these things work if someone's ready and willing to kind of apply those particular those tasks that they have to do to help themselves to win.
So I love this, right? Because see, this gets at, I think, a core PT problem.
Oh, yeah.
This is
that was part of the ones. That was something I want to talk to you today about.
So this right here to me is like, I think, a huge shift for me personally, right?
Yeah.
And so this idea of us fixing people versus helping them manage their lives, however they want to live them,
right.
Whatever that is to them, right?
Yeah.
So, and I think this. And I think it was born of trying to fix people. Like we had all these competitions, like chiropractors do this, but we fix them, and so
we go. It's not just the symptom; we're going at the cause.
We're gonna get all this stuff right, and so there's all these ideas about muscle imbalances and these different things, and we're gonna fix all that stuff. When in fact, it's all normal. It's like it's more common than uncommon, and it's not really related to pain that much. And that's there's all these articles out on that right now. So that's a good perspective, because essentially it's like, what if we decided instead of fixing people, we're going to kind of understand where they're at exactly, what their values are, and then come into their lives at that point and just help them manage whatever they want to manage, and then get out of their lives, even though they have, many different fixable things potentially, right? And just help them wherever they're at, right? And also do things that we think aren't good. I mean, that's the thing I thought was interesting for me. Like I just recently had a challenge, right? And we all know this crazy guy who came to the clinic named, I won't know can't tell his name, but but he came recently, and essentially, everyone was having difficulty with him, managing him, and so I started talking to him, and so I used this idea of value-based goals, right? This is, okay, what do you want to do? And he's had a stroke and he has low back pain, and he's talking about they gave him an MRI already, and he's 75 years old, and he walks with a cane, and he's going to get injections. He's going to go to the pain program.
Yeah.
He's very impulsive, probably some from his stroke or who knows why. Yeah. But a super nice guy, right? And he's just like a typical rural Oregon guy, right? And really nice. But so I'm talking to him, and he says, "Well," I says, "What is something you want to do?" And he's like, "I want to play tennis," and I'm like, well, he's not going to play tennis. He has a stroke. He has to walk with a cane. It's an impossible goal, right? And it's like, so we talked about, we do some other things, and I have him bend and move. And it's obvious he's just really stiff.
Right.
And so probably his low back pain is from
inactivity.
Just inactivity, and he can't move so well from his stroke.
Yep.
Just needs to do some yoga, right? And And so, manual therapy is really way too, micro for what his issue is, right? So essentially, so I asked him again, like, well, what do you want to do? And he says, I want to play tennis, and I'm like, really, Bob? And he's like, you think you're going to play tennis, right? I said his name. You can't put his name in there. Yeah. So I says, really? And he says, like, yeah. And he says, I want to, and I'm like, but Bob, but that's going to be hard, right? It's like you...
We could change his name.
Yeah, Dan or whatever, right?
Yeah, Dan.
But it's like you're going to have trouble, you really think that's going to be a lot of work, and so I tried to talk him out of it.
You're trying to talk him out of it.
And I'm so what would be important to you? I really want to play tennis. Over and over, right? And I'm like, this is ridiculous.
Well, then
right?
You got to go.
Well, so I just thought, okay, I could have, because we had student helpers, right? So I could have one of the students gait belt him.
Yep.
We could put him in a room. They could hold him with a gait belt, and we could play tennis for an hour.
Right.
And then in between each break, we will do all kinds of back exercises to check in with his back, right?
Right.
And so we did that, and he ended up doing 70 sit to stands and 50 forward bends, and because we did in between each break in the tennis thing, he was so excited and motivated to do it. I would have never got that kind of performance out of him. And he was lunging to the left and right and bending forward to hit the tennis ball. It was just crazy, the dosage we got to by playing tennis and lining up with him, even though he will never be a tennis player
ever again,
unless he hires somebody. I mean, he could definitely hire somebody, and I think we're gonna wrap it up. I'm gonna take him outside, and we're gonna play tennis once
on the court.
On a court,
you should,
just to have the experience.
Absolutely.
And just because that's what his goals are, right? Yep. But they weren't. They would have. It took me like a good 4 times to come around to that's what I had to do to really move this forward.
Right.
And as soon as I did, like the last visit, his pain had dropped, several points on the PROMIS scales.
Yeah.
And his low back pain, he said, was pretty inconsequential.
Right.
And he was not going to get injections, and so it had turned the corner for him. So I think one of the things that's happening is like, it's management versus fixing. I'm never going to fix all of the different impairments that this 75-year-old wonderful man has.
Right.
He's earned them. And they were all joys to him during his life, and now he's just has them, to relish as he goes into
he's 75.
his last stage, right? Exactly. He's 75 years old. I hope I have them, right?
I'm likely to have some pain at 75.
But I think it's nice, right? I think, and so that's a great example of going from, like being outside of ourselves and just meeting them where they're at, what do they need, right? And I was thinking about like the frustration many people have, or I would have had early on, if I could have had this viewpoint when I'm working with people, it'd have been a completely different experience, and
instead of doing what we thought was best for them.
Right, parental, like there's this parental approach.
I agree.
And then I also am preparing for a course on Thursday, and so I watched a video from a pain conference. It was wonderful, and it was a woman talking about the experience she had.
Her experience,
But she first gave, she got all the notes from all of her providers.
Oh, wow.
And put the notes up, and that told the story of who she was. And it's like, some year-old woman with, this and that. It's all like, blah, 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 blah. And she says, well, let me tell you about how my experience went. And it's all psychosocial.
Yeah.
See, her experience with us is all fatigue and, meaning and feeling ignored and, not connecting and looking for, kind of some kind of confidence and, all of these different things that are all psychosocial, right? And so the physical part of it was clearly less important since she couldn't solve it. She had complex regional pain syndrome.
Right.
So it's difficult, right? It's a really hard problem, right? So it made sense that she would have some frustration and stuff because not everybody knows how to treat that and everything. So some of it's, since we know the system, we could, it's hard to find the right providers for those people sometimes. But the idea is her what she needed was a lot of psychosocial support. She clearly says on the video 100% that she got gastrin and all these some of these techniques.
Right.
The only reason she liked them is because somebody was touching her and caring for her.
Right.
And when she felt there was nothing else that could help her. And so it was this So there's this completely different reason, which at the moment I'm not sure she could have articulated all that, right? And so
I'm sure not at the moment,
right? And so it's like the question for us is like, maybe she can't, maybe it wouldn't help her to have a psychological approach at that moment, because this is all in retrospect, right?
Right.
But the idea that us being more psychosocial could help us understand what patients need in terms of management and not fixing them, right, would be a big step forward for PT and helping us like spread, our effect on the world. I mean, the data's out clear. It's like we're getting less specialty referrals, right? And our piece of patients that could come to us, we only see 1/10 of them actually come.
Yeah.
And so if we wanted that to increase, I think it would, I think at minimum it would double if they saw us not as parental,
right, but
as somebody they could come to who was more walking with them.
Right.
I think that would change our, kind of
I'm
public view in a big way.
I'm with you on that. I at one point researched kind of we talked about certificate programs here, right? And that's something we're moving forward with, and a number of things. And one of the things I thought of, and with JD here, I think we can pull it off, but a health coach. Because
100%,
we
great.
I think physical therapists have given up these areas to non-specialized people that actually have no experience in movement.
Right.
But they're health coaches putting people on these programs of movement.
Right.
As well as other things.
Right.
And so, but I think what happens though is it's like the CSCS,
right.
It's
right.
Well, as a physical therapist, you should know how to do that. So it's a certificate that's below the knowledge that you get to being a physical therapist itself.
Right.
And so health coaching is that same way. So I think some therapists won't like that because it's like, well, it's something less than our degree.
Well, so
so I wonder about if it would work because of that. But on the flip side, that's the area that needs knowledge, because there's these people that you can take a course, and all this kind of stuff, but you don't have to have any degree.
Right. And so to me, there's two areas that I look like. I love the fact that the behaviors have been successful and people recognize their importance for primary care. 100%. It's wonderful.
Yeah.
And there's a lot of benefit that's probably going to come from that. And the same thing with health coaching. There's these issues that they can address. At the same time, I would say there's a role for a more medically trained behaviorist and a more medically trained health coach. And
I'm with you there.
And I think that's a PT that's psychologically informed. That's my kind of view, basically, whether that's and I think essentially the benefit is, I think diabetes is a great example, right? So because basically you need to know movement and also
physiology
and psychology and understand it. If you had that in one person, that person could drive that program in a really positive way.
Well, in so much as we had a psychology student here that told a diabetes patient that she shouldn't move and she shouldn't exercise, because that's going to change her physiology and make the diabetes worse.
Oh, right, and then they should diet instead. Like they're all
that's bad advice.
Right.
Because this particular student. Psychology student, doctor of psychology student, was not medically trained. Right. And so didn't know the pathophysiology of diabetes.
Right. And so I think it's that kind of thing where knowing about the disease and how movement, and I think what we're learning is that the effect of movement on mood, which we just talked about at the beginning, this puts us in a really good position to influence a lot of the behavior change and behavior issues that they're dealing with in primary care. And I think that's that mixture. And I think it's necessary too to be in primary care. I think the first step is for us to be more biopsychosocial, because what we have to get out of is, if you're going to be in primary care, you can't be about you. You just have to only be about the patient. And so it can't matter if someone else can also step in and help the patient. If that's the best person, then that's the person who should be helping the patient. Right. And so I think it's super important that we have to be circumspect if we're going to be in primary care, and we have to have a certain view. But
yeah.
But I don't know. Like I've asked people on the podcast that I'm doing on 50/50. You know, it's like, is psychological training, is it advanced or basic? Right? Should it be in an entry level program? And you know, the verdict's out. Like people want it to be entry level.
Right.
But my experience is that
what do you have to cut something. Something
right,
has to go.
I don't think you can get there because
I'm with you.
I think because see one of the things I've been noticing in terms of like because I had a bunch of students do calls during COVID, so we called people,
right,
and then we recorded them,
right.
So I know exactly what the students said and how they behaved and the kinds of psychological approaches that they use. We got it all on tape,
right,
and essentially. Students freeze up anytime a person reveals, reveals something uncomfortable.
Well, that's what I meant, confrontation.
That's right.
Uncomfortable.
But it's about their perceptions. They can't turn off. No,
right.
They haven't been trained to like be neutral
right.
and turn off their emotions and meet somebody where they're at. And because I've never quite understood, even in my own self, like why can't I meet somebody where they're at? But I mean, I'll give you a good example. So from one of the students the other day. Had a patient here, and they asked the patient, what's something about stress and emotions and stuff in their lives, and so essentially the patient said, well, my daughter is stressing me out right now. And she's 18, her daughter, right, and the patient's statement was, my daughter at that age, I already had 2 kids and was on my own,
right.
And my daughter is still living at my house, since that was stressing her out. Well, the student took that in, was like, that means she would have 2 kids at 18, and that's really bothered him, right? And so he was judging her because of the, you know what I mean? So it wasn't where the right response was, wow, so you feel like, you were really responsible when you were young and took on a lot of, kind of commitment to family and all this thing, and now your daughter is still not independent, and that's really bothering you. That would be, kind of a neutral, good statement to make.
Right.
But the student couldn't get there because they were too wrapped up in how bad, how that's not okay to have an 18-year-old with 2 children, right? And so where'd that come from?
Right.
And so the training, in the training, you have to somehow our training has to address the fact that the provider themselves, which is the PT student, right, or the practicing PT, has to somehow kind of meet that patient where they're at. That means you have to erase your own biases and cultural things or whatever they are, and you have to kind of say, okay, I'm not condoning the fact that you had 2 children, at a young age, which,
it shouldn't even be in the equation.
It's not even in the equation, right? And that's
it's just something that happened.
It's just something that happened.
And then she got success growing up quick.
Right, exactly, right? But it's like that's irrelevant, right? And
so I wonder, because we've done a new model for the first years after they're done with their first year of school,
right? Right.
So so we had a number of students because of COVID, not be able to go into their clinic, in the summer.
Correct.
So they did in the fall.
Right.
So we had them.
You participated a little bit. I was in a little bit. Yeah.
Right. So. And maybe we could have Dan back on as and see kind of get his after it's finished.
Right.
Last week was last week.
Right.
So we did it for 15, 16 weeks.
Right.
14 maybe. And so my interaction with him recently was so successful.
Yes, I thought so too.
And so I'm going to retract what I said about maybe it's too complicated for students. What if we'd use, because Dan seems to think they're leaps and bounds ahead of where they were. If you compared the students, the 6 or 8 students that did it during the fall, compared it to the students that had just a regular clinic,
right,
these students are way ahead.
So
maybe we can do it. Maybe it's not a didactic piece,
right,
but maybe it's more of a practical piece inside a clinic.
So it's interesting because I was in some of those discussions, and I 100% agree with the advancement, and that because they're getting much more reflection and this kind of psychosocial approach.
It seemed like they were.
Because I don't know where that's being modeled. I mean, I know it's being modeled in some places, but this is 100% all the time.
I think we're leading in that area as
But there's also students though that were in those groups that it's just like they're not mature enough, or they don't have enough experience with it, or they need to have it more repeated, which is with everything, right? I mean, so I don't know, I do think that, handling like I did an easy one with this lady, the example I gave, but there's also examples of like a young man who's 38 years old that had high blood pressure, like his diastolic was 130.
Right.
So he has to be on medications at 38, and he is overweight and Latino, right? And so we're talking about physical activity with him, and then he, drops in that, he just lost he had a stillborn baby, or a little baby with heart defects, and then one of his close relatives died, and that the real reason he's not active right now is because he's been depressed, and he's had a 4-month bout of drinking and inactivity, and now he's trying to come out of that. And so at that moment, right, that all happened in like 60 seconds. Right? And so he just drops it into the conversation. Well, what do you think people did? They're like, okay, let's talk about exercise. They have no capacity to like sit with that person and show empathy, sit and then walk through that.
But that's normal.
But the training should say, okay, let's let that be on the table, and let's let that, like, so where are you at now, and how can we talk about that?
And that's exactly it.
And work with that. So that's where the counseling skills come in. So it's like, how do I turn my emotions off? How do I stay in this conversation without overstepping and trying to be a psychologist, right? And how do I kind of turn it back to, okay, so, but that's counseling skills, right? That's, a lot of them are wrapped up in motivational interviewing, but they're also take experience to like, to kind of walk through that with someone. So it's not exactly something you can just teach, without having that confrontation actually occur with the person with mentoring, right? You know what I mean?
Well, I know that. I think that's why it's working in the clinic, the way that we modeled that, because we had two mentors that were lights out.
Liz Andre and Dan.
Fantastic. And so they've done this now for years and years, and so.
But I'd say that's with what we've been able to show, though, I think, in these videos, and then we'll get this data out in February. That there is actually a process to how the students walk through this, and part of it is first just understanding the rules.
Well, but those videos, I'll give. I mean, the videos, the training for those videos was not like what the training is now.
No, it's better in the clinic. Right. It's better in the clinic.
So I don't know if that's a fair comparison, because they're significantly ahead of those that were just kind of got a little book stuff, some article stuff, some training stuff, some certificate stuff, and then they went and tried it.
But because of the mentoring.
And because of the mentoring.
I agree with that. But I think the process of what you need to go through it is also clear. Like, you have to, there is the first step to make you able to sit, is like you have to be able to shut down yourself. And just be about that person. So and so that is not something everybody kind of is aware of until you get in the situation. Because you can talk about it all day until the emotions hit you, and then it becomes
real.
And then you're like, what am I?
That person is in front of you, and they just had all these things. They just barfed on you. And you've got to fix it.
And you have to walk through it, and walk with them, and not get all caught up in all these side stories, and then get back on their values and not try to fix it. Because I can't bring that baby back from the dead, and I can't make the relative come back to life, and I can't stop the fact that they already blew 4 months of their life. I can't reverse any of that, and so that's all real. And so
it's meeting them exactly where they're at.
So how to do that?
So we have to model that. So I'm a big fan of that. So we were in Uganda. And went to this boarding school, Goodwill was the name of the school. I don't know if it was it was after JD's, I think, time. And so a little boy with autism, you could tell. And then, but the caregivers there, administrators and teachers, I thought it was behavioral.
Oh, okay.
So during meals, the little boy would throw us food.
I think, was I there?
You might have been there.
I think I was there.
And so
keep going.
And so so they're disciplining this, I don't know, 7-year-old little boy, and it was sad to see. And so it was mealtime, and then so I asked if I could help. And so, because the students are not knowing what to do because he's being disciplined.
Right.
And so that's weird, right?
Right.
For us looking at that.
Yeah, so
Spanking
it's corporal discipline.
Yeah, so
spanking.
Spanking's okay,
yeah.
right? And so, in that particular, culture, in some of that, the way that they discipline.
Right.
And so, because they're thinking it's behavioral.
Right. He has a choice.
Yeah, it's choice. And so, I sat down with him, and we ate. And so the little boy, I could tell when the porridge, you've been there, it runs through. So they eat with their hands a lot,
right?
And so the little boy's eating the porridge, but it's running down his arm, and you could tell just the feeling of that porridge on his hand bothered him.
Right.
So he'd take a bite, and then he'd go like this.
So he wasn't really trying to be bad.
He wasn't trying to be bad. He was trying to get this stuff off his hands.
Yeah.
And so I sat with him. And you could tell he was a smart little boy. He just couldn't communicate. So I wish we knew knew more about speech therapy, speech pathology, because it was like, oh my gosh, he's vocalizing, but he's super smart. He understands me, right. So that's kind of weird, and he can't communicate, and so we ate together, and at the end of it, he's not throwing his food.
Oh, that's great.
But I have food all over my face, and in my hair, all my clothes.
Because he got it on you?
Yeah, because he's sitting there with me in my lap, and he'd eat, and he knew that I need to get it off, and so he's wiping it on me and getting it off, and in a short amount of time, the students saw that was the model.
Right.
You could be lectured to all you want about how to correct.
But how are you going to sit there and let them
put
the oatmeal on your body, right? Yes. Are you willing to let them do that to you?
Yeah.
It's the same. I think it's the same.
I'm with you.
You're walking with them.
I think it's exactly the same.
Being in their zone and then trying
messy,
to understand.
It's you mess up. So, I don't know, these ideas, when we first started to get this idea that the psychosocial component affected bio.
Right.
We practiced a lot, and we were in primary care,
right?
And so we had the opportunity to do that,
right?
So,
well, that's what the course is about this weekend. But I mean, I think that's.
But how many mistakes? I made mistakes. Did you make mistakes?
Oh, so many. And then, but I mean, the turning points for me are numerous, right?
Yeah.
But one in particular is like, lateral shift. Have you ever seen somebody with a lateral shift?
Yeah.
They're tremendously difficult.
No, I know, and you're taught how to try to do that.
We all have all these correction and manipulations, and my experience is they're totally 50-50. Like you have, you can go in, and I actually, after doing many of them over 20 years, right, is that getting them, knowing that you're going to get them right is just it's a flip of the coin,
right?
And even though I have lots of training, right? And so when I saw a patient, that had that, and I was frustrated, but talked to her about all this stuff, and then Dan saw her and did nothing but psychosocial, and she corrected in the room as he was talking to her without ever touching her. That was to me the
turning point.
The turning point, right?
A shift.
Even though we'd already had several examples of when you had manual therapy and stuff like that, the fact that somebody could be completely contorted voluntarily, because of fears and emotions and things like that, that was just phenomenally remarkable, in every sense of the word. I would never have argued that was reversible by, psychology.
Right.
And so at that moment, I was very, what do you want to call it, disrupted.
Right.
I could not, I was like a ship without a rudder. I had no idea what I was supposed to do except learn about psychology.
Right.
And
so for our listeners and watchers, that's all he's been doing for 3 years. So he's abandoned biomechanics.
That's not true.
He's going to go back to it, by the way. So
I have a 50-50 perspective. I do have a 50. I think, to me, I think what's going to happen with me personally is I'll probably rediscover the some of the impairments and stuff like that. But I'm willing. I think this has been a pattern for me my whole life. It's you have to give to let. It's hard to let stuff go, right? And I think I mean, I think that's a real thing. Like, how do you let stuff go, right? You have a funeral ceremony for it. I mean, what are you going to do, right? But you need to actually let stuff go in order to try something new. Yeah. And I think we always have this sense that, you know, by not doing something, it's like wrong, right? Because that's what we've done, and we know something about predicting that outcome, so we can have a better relationship with our patients because we know exactly how that's going to occur. Right. You know.
And that's something we want, I think, our listeners to know, you know, and viewers, because that we don't do everything right.
Oh, no.
And we're trying to model what the best practice is. And some of that is practice.
It's experience.
It's experience and judgment, and it may not just be in the books. And so...
But I would say two things. Yeah. I'd say one of the things that I think is important for psychology in the psychological realm, like as we're learning, there is no way, in my view, to do psychologically informed PT without doing outcome measurement.
Yeah.
Because that's what measures psychological factors. Yeah. Right? You can measure physical factors without doing outcome. You can measure range of motion strength and functional tasks and sit to stand, stuff like that.
Well, those are outcomes, though.
They're outcomes. No, they're outcomes. But I mean, you have to get outcomes that also reflect depression and self-efficacy and things like that. Yes. And so you can't rely on your gut. Right. And there's lots of evidence for that. And I'm happy to share that. Right.
But so PTs guess wrong,
and you'll learn way more about how in a much truer way if you use outcomes. And you can use whatever you want, but you need to use outcomes to know if you're affecting that.
Yep.
That's the first part of learning in using psychologically informed PT.
But don't the outcomes also tell you where you can start?
Yeah. They also tell you. I mean, one of the things that's interesting, like as an example, like I think both Steve and George, and then in our data, I thought, Steve and George, of course, is fantastic and way better than anything I've done. But the nice thing about something he's done recently is they've been doing these measures of like let the patients determine like some of these variables that they want to be treated for.
Okay.
Emotional distress is one, but one that's been really ignored by us is fatigue.
Right.
And that directly correlates to what we're picking up on our promise. We've thrown fatigue in. Fatigue is...
Yeah, Lazandre started actually attacking fatigue specifically when she noticed that those measures were low.
Right.
So, or fatigue, high fatigue.
High fatigue, and then you want to...
and that's just like, that's what we need to work on.
Well, we're working on data right now from not just GFU clinic, but some of the clinics around here that is consistently showing fatigue as a big problem for patients that they experience that we just is invisible to us, even though we're kind of addressing it. It's both an emotional and a physical problem because it kind of it embodies both. You have this inertia component and this this physical tiredness. So it's kind of a interesting variable because we usually think of it as physiologic, but it's also partly motivational and psychological. And so I think what's super interesting is that is also important for us to start thinking about the patient's point of view and what's important to them, in the psychosocial domains.
And I guess that's what hooked me was when because that's the snapshot into the patient.
Right.
That's what the patient just said.
Right. And then just without in some screening way, right?
Yeah, without us filtering.
Right.
Because it's they said that.
That's right.
And so for me, that was a. I don't know. I don't know. Maybe I'm just lazy physical therapist. Because for me, it was like, now I know.
Right.
Because now that helps me kind of direct treatment.
Right. Yeah. It's just how do you know your patient better? I mean,
that's right.
I would just say, it's funny trying to get people hooked on this or excited about it. It's like, everybody wants to know their patient. Everybody thinks is compassionate. Yeah. Everybody has empathy for their patients, or they wouldn't be doing what they're doing.
Right.
I think, but the viewpoint's been is that by being better at skills like manual therapy and being all about that,
all these certifications.
That's where their empathy is driven. It's like, I'm going to be very good technically and all this kind of stuff. I'm going to fix people.
Yep.
Right.
All the way back to that.
This is, and people appreciate that, and it's true. Like if you can fix them, if you could really, really fix them, you should do it. Right. I mean, that's really true. But
because there is bio.
That's right. Yeah. It's real. But
it is real.
But more patients want or need to be fixed.
Right.
They need management. And so in that case, it's really psychosocial, right?
Yeah.
And so I think the
it's not
balance of
forgetting
those,
the bio, because the diabetes, it's bio first. And but the psychosocial does influence.
But how to get
it, so.
somebody who's 300 pounds to lose weight because that can reverse diabetes, that's psychosocial.
Yes, it is.
Right? And the physical benefit of it is 100% clear.
Yeah.
But I think that's the same as chronic pain patients and things like that. They are wrapped up in psychosocial problems.
Right.
In the physical part, like, it would help them. That's the thing. What?
Right.
Mood follows action.
Mood follows action.
So it's how to get them to act.
Yes.
Right? But that's behavior change.
Right.
I think we end there.
Okay.
Because it's an hour, right?
Has it been an hour?
Yeah.
Wow. Great topic today. Great conversation today. Thanks for listening. Thanks for tuning in. And just make sure you're connecting with us in some way, whether it would be liking or subscribing. You can connect with us directly, and be sure to visit our website, motifcenter.com. And if you want to be featured in our Q&A, send us a question. We'll be happy to answer that in our Q&A session, and let us know where you're coming from.